Hi, I'm Dr. Donald Jurovich. I'm a professor of geriatrics at the University of North Dakota and the department chairman. Today I'd like to talk about medical management of dementia. Today we want to look at the three-pronged approach to medically managing Alzheimer's disease and its related dementias. We'd like to review the appropriate medications for dealing with neuropsychiatric symptoms in Alzheimer's disease. And we want to know when to optimize and then to de-escalate medications during the course of the disease. And then finally to review non-pharmacologic interventions to reduce neuropsychiatric symptomatology. So the three-pronged approach in dementia involves functional problems, neurologic, and behavioral problems. And as it turns out, the cognitive decline goes one-on-one or hand-in-hand with functional declines. So it's not known if one stabilizes function, whether you also stabilize cognition or vice versa. But these are important concepts in terms of tracking the overall deterioration of a dementing illness. Likewise, in neurologic problems, one has to be on the lookout for acquisition of neurologic problems such as cogwheeling that you might see in a Parkinsonian-like development of Alzheimer's disease. And if you find that the cogwheeling is in both extension and flexion, also known as Gegenhalten, that there might be another condition rather than Alzheimer's, namely progressive supranuclear palsy. So again, some of these presentations of dementing illnesses present with asynchronously problems. The neurologic problems can occur sporadically at any point of the disease, as we'll see here shortly. So for a moment, just think about some of the neurologic complications of dementia. Just list mentally just one or two problems that you think occur. Okay, so let's take a look at what those complications might be. So at any point in the course of the disease, Alzheimer's patients can develop seizures, either in the early, mid, or late part of the disease. As mentioned earlier, they can develop extrapyramidal symptomatology. And if they do, patients with EPS, extrapyramidal symptoms, tend to have a more rapid deterioration. And that's important to let family members know in terms of prognosticating. They'll ask, well, how many remaining years of life expectancy can we think about or plan for? So the autonomic nervous system goes awry with Alzheimer's disease. Urinary incontinence increases by 1.5-fold. Almost 2/3 of patients with dementia have clinical dysautonomia. A large percent of them have orthostasis, where the systolic blood pressure drops considerably. And likewise, people with dementia will have, at least 1 out of 5 will have urinary and bowel incontinence. And just to remind us that obstipation or constipation are 2 side effects of autonomic dystrophy. So looking at pharmacologic interventions for dementia, the goal overall is to try to stabilize. Certainly the possibility of reversing cognitive impairment is an important concept. And simultaneously, we want to prevent a functional decline. Oftentimes we're called upon to treat or reduce the symptoms of behavioral problems that occur during the course of the dementing illness. So treatment of neuropsychiatric problems in dementia include addressing depression, anxiety, agitation, delusions, and most difficult to treat is disinhibition, particularly sexual disinhibition. Some investigators are thinking in terms of symptom clusters during Alzheimer's disease, and that rather than just treating one particular symptomatology, that there might be a triad or a dyad of symptoms that need to be addressed concomitantly. So what about the antidepressants? Most of the studies show that there can be clinical significant improvement by treating depression with dementia, and that there is a possibility of symptom remission by doing so. Overall, though, the depression studies in dementia show mixed results. They're tilted in favor of SSRI use as opposed to other classes of antidepressants. And some of the unanswered questions are related to withdrawing antidepressants in the later stages of dementia. So what about the randomized controlled trials? Here's a couple here that we're going to look at. The Health Technology Assessment Study basically is a randomized controlled trial that compared placebo with sertraline or mirtazapine. Turns out mirtazapine is a little bit more sedating than sertraline. And also I just want to point out that sertraline really takes a long time to activate, and that's an important consideration for this study because none of the doses for either of these medications were maximized. So the overall study showed a slight improvement with the antidepressants, but not statistically significant. And an important take-home from the study was that there were more side effects with the SSRIs than with the placebo, remembering that SSRIs can cause hyponatremia as well as QT prolongation, in addition to other gastrointestinal side effects. So the citalopram study showed some effect. There were 3 scales of rating here that include the neuropsychiatric inventory score, which is a very popular research tool that also can be used clinically. And so this study found that citalopram reduced delusions, anxiety, and irritability significantly with a reduction in the odds ratio, but then less of an impact on depression and dysphoria. The question of withdrawing antidepressants is a mixed bag. So in this particular study, they showed that the continuation group with the antidepressants had lower neuropsych inventory scores than the withdrawal group. But depending upon the scale that was used, one found a difference and the other one did not. So the big question is whether antipsychotics, which have enormous downside in terms of side effects, including death due to stroke and heart attack, some of the studies show that there is a overall reduction in agitated behavior with the use of risperidone at increasing doses. So you can see that the 2 milligrams over a 12-week period reduced neuropsychiatric scores, but not by large amounts. So it's only a 2-point difference. And so one really wonders whether that's really worth the risk of the medication for such little gain in neuropsychiatric changes. Another question comes up as to whether the acetylcholinesterase inhibitors might impact Alzheimer's behavior, and there's 14 randomized controlled trials. And of these, only 4 reported global improvements in behavior. And this was for people with moderate dementia rather than severe. And there was no impact of acetylcholinesterase inhibitors on depressive symptoms. What about memantine? Well, it turns out that memantine showed some improvement in neuropsychiatric scores, but only for moderate to severe and not mild demented patients. So this might be a good medication to start in midstream of the dementing illness when neuropsychiatric symptoms are manifest. Interesting study here done a few years back that showed that memantine reduces opioid-induced cognitive decline. So you can see here that the number of errors on a standardized test were reduced considerably, and different parts of intellectual function were improved. However, I want to make a point that the fact that opioids do cause cognitive decline, I often tell my patients that, you know, this pain medication that you're on could be associated with memory loss, something like Alzheimer's disease. And that tends to be a good point of discussion, particularly with those patients that are on low-dose opioids. Maybe they take a bedtime dose, and they'll use that bit of information about dementing illness as a reference point for either de-escalating the medication or discontinue it entirely. So one of the big problems in dementia is agitation, and how do we deal with it? So half the people with dementia have monthly episodes. Of these, the vast majority remain agitated over a 6-month period. It has a ebb and flow manifestation for it, and it's always difficult to treat both in the short term as well as in the long term. There are two tools that are used to formally monitor agitation-like behaviors. It's the Cohen-Mansfield Agitation Inventory List, and then the MPI that we had mentioned earlier, which is the Neuropsych Inventory. So this is the Cohen-Mansfield Agitation Inventory. It lists all the kinds of things that occur with agitation, such as biting, scratching, spitting, hitting, self-mutilation, pacing. So always remember that people that are walking aimlessly back and forth, that is a form of agitation. And the nice thing about this score card is that you can identify the intensity of the symptoms and see whether your intervention moves the needle to the left here. So in terms of acetylcholinesterase inhibitors, while there's modest improvement in overall neuropsychiatric symptoms, the subset of agitation is not really markedly impacted by these class of drugs. More to the point is this protocol that was developed out of a British study that empirically treated agitated, demented patients with pain medication, starting with acetaminophen, 1 gram 2 to 3 times a day. If that didn't work, then escalating to low-dose morphine, and again, increasing the dose of the medication for testing efficacy. We don't really use buprenorphine, and so the next step for us would be pregabalin, particularly if there's neuropathic pain. And here you can see in the red dotted line that according to the Cohen-Mansfield Agitation Scale, that there was a significant decline in agitation symptoms by using this pain management protocol. Again, that's using Tylenol first, morphine second, and then pregabalin thirdly in an escalating dose, and not in a summative way. You know, you don't, although I suppose you could maintain the acetaminophen and then add morphine, but the study actually just switched over from one to the other. So the take-home points from the study is that empiric pain management reduced agitation in by nearly 20%. Importantly, cognitive status did not change with the pain medication, nor did the activities of daily living. And so it really emphasized the fact that pain treatment it really should be the mainstay of empiric intervention in older adults with agitation and dementing illness. So what is the impact of antipsychotics in controlling agitation in demented states, both in terms of the short-term and long-term effects? So acute agitation with evidence that the patient is going to harm themselves or others, the American Geriatric Society advocates Haldol either orally or intramuscularly, and you escalate the dose every 30 to 60 minutes, doubling the dose, and then reassessing. Always keep in mind that you need to look for underlying medical problems that could be causing the agitation, such as urinary tract infection, metabolic disorders, hypoxia, and so forth. So once you've controlled the agitation, you then provide a maintenance dose that is 1/2 of the initial dose, and you provide that twice daily. After 3 days, you attempt de-escalation with a gradual tapering dose of the antipsychotic. And if it's not working in terms of reducing agitation, then it's best to switch from Haldol to risperidol or quetiapine, with the caveat that quetiapine is preferred in Lewy body dementia, Parkinsonism, and AIDS dementia. So one of the questions is, can we predict the relapses of agitation and psychosis after stopping the antipsychotic? And it turns out that people with auditory hallucinations are refractory, and that they are more likely to relapse than people with visual hallucinations. But overall, studies show that only 11 to 13% of patients with dementia and agitation actually benefit from long-term use. So you can use that as kind of a rule of thumb, that if you have a panel of patients that are on antipsychotics, it should only represent about 10 to 15% of the entire population that you're dealing with for agitation. An important point is that antipsychotics increase hospital-acquired pneumonia, and so these medications are not without risk. Also mentioning the black box warning of increased stroke and heart attack due to these medications. And so you can see that there's a definite hazard ratio for using antipsychotics. So they are associated with a higher mortality and really need to be used with great caution. Our efforts to reduce antipsychotic use is represented here in North Dakota, where, well, the study is a little old now, but it shows that there was about a 4% decline in antipsychotic use, which is not a spectacular reduction, because there are some states where 5 to 10% of the nursing home population take antipsychotics, which is more, I think, a laudable goal, given the multiple side effects of these antipsychotics. I also want to point out that you can't order Haldol PRN. So if you refer somebody to a nursing home from the hospital with PRN Haldol, it's not going to happen. And in fact, if they are on Haldol, you have to write orders for de-escalating the dose over the next 1 to 2 weeks. So there's other approaches towards treating behavioral disorders and Alzheimer's disease. Citalopram has been used for controlling agitation, as anticonvulsants, and then you can see these other medications, some of which work marginally, others that don't work at all. You might ask, well, why use prazosin? And the reason was that that study was linked to prazosin being effective in traumatic brain injury, and it turns out it's not so effective in brain deterioration due to Alzheimer's disease. So using the anti-epileptic drugs, you can do a trial of low-dose valproic acid, and they don't always work, but sometimes they're used to reduce the frequency of agitation in the older adult with dementia. Dronabinol mixed effects with this medication, my own experience has been that it's sometimes not as effective as some of the randomized controlled trials show, including changes in appetite and hyperexcitability are some of the observations I've had with this medication. So that leads us to the question of non-pharmacologic approaches to agitation and dementia. So what is effective, as I pointed out, was pain management for reducing symptoms. Long-term exercise is very valuable, as is music therapy, and I want to point out that some studies show that harpsichord, live harpsichord rather than digital or CD-based harpsichord music is effective, and there's some thought or speculation that harpsichord music improves parasympathetic nervous system tone, which is the more sedating part of the nervous system. Non-effective, unfortunately, is aromatherapy and bright light therapy. So this study shows the reduction in, according to the neuropsych inventory score of long-term exercise. And an important point in medical management of dementia illnesses is to educate the family and caregiver. So it's really important to stress with the family to have them not argue with the patient, making correcting gestures, pointing their finger at them, or saying, "Mom, you know, come on, Mom, you can remember," or to even do any type of reasoning with the older adult with dementia, because these all go very circular and they start to spiral downward into agitation and very frustrating for the demented patient. You also want to educate the family on improving nonverbal communication. So, smiling when even if the older adult with dementia is doing something that they don't particularly like, you always want to put on a disarming face as opposed to the frown, which may get the patient with dementia all worked up, thinking like, why are they frowning? There's something wrong here. So it increases their anxiety and their agitated behavior. And then finally, you want to redirect the patient with different things, like a promise to go to another place, or food as a distractor. These are all important elements for redirecting the patient. So I want to point out that patients with Alzheimer's live longer if their caregivers have training. And likewise, there's less caregiver distress. So it's important to take care of the caregiver in your management of the cognitively impaired patient. So that leads us to our summary. We always want to focus on the functionality of the patient, both in terms of their neurologic function, their physical function, as well as their cognitive function. The behavioral changes that may crop up from time to time may reflect an underlying medical problem, such as urinary tract infection, metabolic disorder, hypoxia, and so forth, unresolved pain. And all these need to be assessed on a systematic, routine basis when there's been a new change in behavior. Whenever possible, try to use non-pharmacologic approaches towards managing behavior. Sometimes when people have, for instance, visual hallucinations or auditory hallucinations, you ask them, does it trouble you? Are you bothered by these? And if they say, no, I've gotten used to it, then maybe treating with a medication is not really warranted. But again, it requires constant monitoring and feedback from both the caregivers, importantly, as well as the patient themselves. Whenever possible, you want to de-escalate antipsychotics. This is particularly true in post-hospitalization, where the older adult may have been hospitalized, had an episode of delirium, and was given Haldol. And if that's the case, there should be a systematic approach towards de-escalating the medication and trying to eliminate it entirely. And then finally, the point that we just made here at the end was treat the family and the caregiver as well as the patient. There's a lot of research on caregiver stress leading to increased hospitalizations. And of course, if the caregiver is hospitalized, then who's going to take care of the patient? So it's with each clinic visit, it's always good to ask the caregiver how they're doing. And even there's tools of assessment to evaluate caregiver stress, which I highly encourage. So with that, I just want to wrap up by saying that if you have the ability to refer to geriatrics for comprehensive geriatric assessment, this modality works. And you can see here that for all the studies that have been done in terms of hospital-based and clinic-based geriatric assessment, they all show improved outcomes and lower cost for the older adult. So referrals for geriatric assessment are to be encouraged. Very good. Thank you for your attention, and look forward to you continuing this series, online series for geriatric knowledge and skills.